Welcome to the SIMS podcast, where we explore the significance of selecting the right outcome measures in patient treatment. Accurate assessment of progress, medico-legal reporting, and academic publication are crucial aspects of our practice. I am joined by Dr. Chetan Patel, a plastic and reconstructive surgeon, as we discuss a compelling case of an angle grinder injury. Together we compare the DASH and upper limb functional index tools with Chen's criteria for postoperative functional evaluation of severed limb replantation. Dr. Patel and Robyn Midgley offer invaluable insights for therapists and surgeons, highlighting the advantages of the SIMS technique in managing complex injuries.
Impairment after injury using patient-reported outcome measures that assess activity participation to determine functional impairment of the upper limb. So current upper limb regional self-improvement report measures are criticized for poor clinical utility, including length, ease and time to complete and score, missing responses, poor psychometric properties. So to address these concerns, a new measure, the Upper Limb Functional Index, was developed with reliability, validity, responsiveness being determined in a prospective study. So the original Upper Limb Functional Index was first published in 2006, not 16, with a dichotomous response option, and it was later modified to a 3-point response that resolved clinometric limitations surrounding psychometric properties with improved practicality. So studies show that the Upper Limb Functional Index correlates well with the DASH, and it is suggested as the preferred upper limb regional tool due to its superior practical characteristics, clinical utility, comparable psychometric properties without a tendency towards redundancy. So it is the preferred tool, and you have a 10-item short form of the Upper Limb Functional Index, which has 25 items. And it was developed to further enhance the practical properties by reducing therapist and patient burden through this ease of administration, scoring, and missing responses. And this 3-point response option also reduced the potential for item redundancy. It contains 10 items with 2 broad constructs: assessment and health-related quality of life, upper extremity dysfunction, and it's presented through a single summated score of a 0 to 100% scale. So what they do is you take the upper limb raw scores, which range from 0 to 10, you convert it to your 0 to 100 percentage scale, where the lowest is 0, which indicates total functional limitation, to the highest score, which is 100%, which is indicating maximum function or pre-injury status. And this reflects the individual's overall capacity and status as a measure of ability rather than disability. So it's only 10 questions and it's really easy to implement. So an optional 5-item specific index, or a PSI section, is also present to interpret the qualitative information. And then there's a further 10-point numerical scale rating of global function, which concurrently assesses overall status. And both these scales are also scored as a status or an ability scale, with the maximum being the pre-injury or the normal level. And what I like about it is you can plot your scores, and on a simple graph, you can see where your patient started to where they ended up on all 3 of those scores. And you can demonstrate this very nicely in your medico-legal reports.
So let's start with our index case, and this is a case that Robyn's treated. This gentleman sustained essentially a grinder injury to his right hand, and this was a dominant hand injury. He's in his 60s. He's a right hand dominant. He makes set equipment, and certainly he's very manually dexterous with his hands. So he sustained injuries to index, middle, ring, and thumb. The thumb was a total amputation, and the index, middle, and ring were various degrees of subtotal amputations. To begin with, this patient arrived, and they never arrive at 8 o'clock in the morning when you've got a list available. They always arrive at when it's least convenient for you to go to theatre. So the first thing is to decide with the patient there and then what is doable and what isn't. Now, just to show you the intricacies, or not, I suppose, the individuality of each case that comes along, and why you can't set a protocol to this, is that this patient happened to be seen in Johannesburg at a time, probably some mid-afternoon. He had come and been referred by another emergency room to my rooms. And at the time that he was referred, I first found out that he was not covered by medical insurance. So this placed an extreme demand on myself in terms of deciding, well, how worth it is it then for me to go into an operating room and put this patient into the operating room, knowing that he would then be covering the costs of this surgical procedure by himself or with the help of friends. And having that as a precondition to start with, I think places a fair demand on both the surgeon and the patient. Be that as it may, we decided that we would do a reattachment of whatever we could as fast as we could in the time that allowed. And so we went ahead and I did a thumb replantation. And that's really just the basics of a thumb replant. That's a surgical discussion, which we can certainly go into in more detail during the discussion. And at the end of that replant, he's got pretty good perfusion to that thumb. In my view, the perfusion's probably a little bit quick, which would indicate to me at that stage that there may have been a venous congestion problem. However, at this stage, I did not have the luxury of redoing an anastomosis, which I'd already done twice. In addition, we K-wired the other fingers, fixed flexor and extensor tendons where appropriate, and continued. So we ended up with this at day one. And I have a habit of removing all of my dressings at day one. And I also have a habit of, under strict guidance by myself, allowing that patient to appreciate their wounds and not covering them up from them at all. So this is purely a day one where I am not doing a thing. I'm asking the patient to actively move, but totally under my guidance. And I think this proves to me that if I'm unhappy with my repair, I'm going to be unhappy with it on table. In this particular case, the gentleman or the patient in question had a general anesthesia, and so I wasn't able to test it on table. But certainly in any cases where I'm able to test the repairs on table, an active test on table is advocated and is certainly the right thing to do. So day one is the best time to generally do these things for me, because they sometimes have a persistence of that nerve block that we've used for them at the time of the operation. And so the pain and the perception of pain is also different when you allow your patient to then see the injuries that they have and to appreciate the brain-hand connection from day one. However, on day three, despite heparinization, and we didn't have any access to leeches at this stage, so I decided at that stage, due to costs for the patient as well, once this point was reached, to decide on an amputation and a closure, which we then subsequently did. So the patient was left with that sort of a hand, and this was kind of 3 months out, with a shortened thumb and various degrees of motion in all of the other joints and fingers. Now, in a mutilated hand such as this, or in a hand, I'm not expecting, my expectation for the patient and either myself is not to expect a perfect hand. However, what I want from this point in is now to get onto a discussion with the patient as to what does he need, what does he have, and what can I do to improve it. And this is where secondary procedures come into discussion. Up until this point, you really need to ensure that soft tissue cover is paramount and is well and properly done. You also need to ensure that the hand has gotten to a stage where it's healed adequately and where there's a fair degree of range of motion. And I think later on in the questions and discussion comes up, what protocols do we use, or what do we favor in terms of treating severely swollen, stiff hands? And one of the things that myself and Robyn have done over the years is treated this with the casting mobilization protocol, which Robyn uses. I have found this to be very helpful and extremely safe when it comes to allowing patients to get a link between their hand injury and those joints which are working can then be supported so that those joints which are not working can then be improved upon by isolating them, but isolating them in a way that requires them to actually use them every single minute of every single day within that cast. And then every week or every couple of weeks, having that splint rearranged so that a new joint is then involved in the therapy. So the ultimate fixation for the patient was an arthrodesis of the proximal interphalangeal joint. And that was done to the middle finger, as well as an external fixator placed and bone lengthening done for the right thumb. The patient elected on a bone lengthening as opposed to a free toe transfer. Once again, at this stage, he was more concerned with the morbidity of free toe transfers. And again, it shows you the individuality that's based in these decisions, because there are many, many ways of lengthening a shortened thumb. But you have to discuss those ways with the patient in great detail to then decide on what is best for the patient, and sometimes not what is best for you. Because as a microsurgeon, my brain is just wanting to do a free toe transfer on this patient. However, as a hand surgeon, I really have to think of the benefits to this patient versus what the benefits to him that I know he will get from the free toe versus his anxiety regarding sacrificing a toe on his foot.
So the only technique that can address multiple problems simultaneously whilst regaining a normal pattern of motion is the Sims technique. So treatment is determined by the phase of rehabilitation. We have the early, middle, and late phase. In the early phase of treatment, the focus was on edema, wound healing, tendon and soft tissue healing through splinting and elevation and active mobilization of the digits, as well as conscious attention to the hand to avoid hand neglect. This phase can last between 0 to 2 weeks, and it is critical to address psychosocial issues early on in the treatment. We forget that an injury like this is extremely traumatic, and it has an enormous impact on every area of that patient's life. We have to refer for trauma debriefing and encourage the patient to discuss their fears and concerns. And this support is paramount to a successful outcome and to compliance with therapy programs. In the middle phase of treatment, the Sims technique was applied to reduce the multiple joint stiffness that had developed. I just want to play you the video. So I provided him with an intrinsic minus cast. I knew that I was not going to get any motion at the IP joint.
Just try and pull the index a little bit more.
Not of the IP joint of the middle finger.
And straighten. And again.
So the aim here was to reduce the edema and to improve tendon glide, to re-establish a normal pattern of motion. And once digital stiffness had resolved, then the secondary thumb lengthening procedure was performed. And with the X-Fix in situ, all we could really do was maintain the improvements made. But because we had applied the SIMS technique early, Chris maintained a normal pattern of motion because we had influenced the somatosensory motor cortex of the brain. And then when we moved into the late phase of therapy, we then could do mirror therapy, laterality, graded motor imagery, functional retraining, 3D printed prosthesis with prosthetic training. Now, Chris actually made me that mirror. When I did mirror therapy with him and I used my little mirror that I've had for years, he decided that the design wasn't good enough and that I really had to make him a new one. He wanted to make me a new one. But he had to go and use the very panel saw that had sustained the injury in the first place. And because of that, he had to embrace his fears. So incidentally, I was doing OT with him, but he'd come up with this idea himself. And so he embraced his fears and he made me this mirror and he was so proud of it. And it was also just his way of saying thank you. And, he just knew that every time I used it, he would, I would think of him. So, yeah, I think if you can encourage activity participation, that is just the best therapy. But in all three phases, one must be aware of the impact on the somatosensory and the primary cortex of the brain, and ultimately the impact on hand function. With regards to Chris's case, he scored 4 points in the upper limb functional index on the 23rd of September, which indicated a 40% of the items listed were problematic or difficult to perform as a result of his injury. So the raw score of 4 out of 10 converts to a 60% functionality ability. And the patient-specific index represented 56% effect on 5 key functional activities. Now, what was important was that Chris's perception was that he was able to perform 50% of his pre-injury duties of the affected hand. And the upper limb functional index assessment score demonstrated an improvement in functional ability since the time of injury, but it was still limited as a result of the injury. So the subjective scores correlated with the objective scores as well as with my biometrics E-Link assessment. And this is really important when you're doing a medico-legal, because you're wanting to show consistency and you're wanting to show that the patient is not malingering and that your assessment is accurate. So if you've got a tool that brings this all together, then I just think that it is just priceless. So the biometrics E-Link is what I use, and I'm in no way promoting it, or I have no affiliate contract with the biometrics E-Link. I've just used this tool from when I was working in London and then purchased it myself, and I use it as both an assessment and a treatment tool. It is called the Upper Extremity Impairment Software, or the ICSW. It uses the American Medical Association guides to the evaluation of permanent impairment, revising the 4th and 5th editions. And this is Chris's assessment. So I can record his dexterity and it just generates a report bringing in graphic images of his, dexterity, of the sensation, and you can very clearly see the red shows complete loss of protective sensation, diminished sensation in the majority of his hand, and then the normal aspects which are represented in green. Here you can see it gives you a very nice demonstration of your grip strength. So I can then show that the right has a bell curve, which is normal, but it is obviously a lot weaker than the left, but not too badly. And then when you do the rapid exchange test, this completely eliminates any malingering concerns because the patient cannot think about what they're doing when they're alternating with the dynamometer. So you can see that actually he was able to maintain his strength between 20 and 25 kilos, whereas when he did the static test, he had 15 kilos. He peaked at 25 and then he dropped down a little bit, although it's a normal bell curve. And you can describe what you're seeing in your medico-legal report, referring to peak forces and averages of force, which the software provides you with tables of those details. You can also look at their endurance, and you can see that the left and the right both have good endurance, although the peak in the left is 40 kilos versus only 25 kilos in the right. And again, you can see that it's consistent through the 3 strength assessments. Pinch strength gives you a very nice table. You can look at the coalition variant percentage. As long as that's below 15%, then it's within normal range, even though his pinch strength is significantly weak. It's not too bad. It brings you up your charts with your manual muscle test, your 2-point discrimination. You can clearly graphically see what's normal and what is impaired and to what degree it's impaired. And then the impairment calculation. So the software takes all of the scores, takes the patient's age, it takes any amputations or arthrodeses into account, and it works out this calculation, and it gives you a very detailed assessment. So the upper limb has actually got an impairment of 15%. The right upper limb has got a 56% impairment, which is giving him an overall 40% impairment. So the take-home message is that you absolutely need to work as a team, patient, surgeon, therapist. It is crucial. You need to be aware of the psychosocial implications and address them as part of your approach. Take very good photos and videos all the way through. It means much more than your range of motion measurements, and it's much faster. You want to spend time with your patient, and you want to demonstrate tissue change, and you can only really do that through video. Apply the SIMS technique early, and use graded motor imagery and mirror therapy along with functional activities as much as you can. And engage your patient. Help them face their fears. And again, as Chetan says, just develop a really good relationship with them.
Maybe, Robyn, I'd just like to start off with Chris's case study, if I may. I think your assessment in terms of getting a outcomes evaluation that is standardized and that everyone understands is important. In terms of, in general, there's an outcomes measurement called the Chen scale. Now, Chen's outcome measurements were used for major upper limb amputations. And this is pretty much from 1995. And Chen's criteria were grade 1 to 4. And all his criteria said was grade 1 is able to resume original work, range of motion exceeds 60% of normal, complete or nearly complete recovery of sensibility, and muscle power of grade 4. So, and then he goes on to grade 2, 3, and 4, where it gets, grade 4 is an almost no usable function of survived limb. So the thing I like about Chen's criteria is that they are extremely simple. Grade 1, 2, 3, 4 can give me a quick idea. However, in order to say that someone is able to resume some suitable work or resume original work is really quite broad. And I think that's where upper limb functional indices and DASH scores are far more sensitive to each intricacy within it. I think we've also got to just say, in a severe upper limb injury, is it more important to know that a patient can have a grip strength of 67 versus 75%? Or is it more important to know that the patient is able to, say, for instance, in Chris's case, get back to using the circular saw or not? And I think these are some of the questions that still need to be answered. And unfortunately, certainly I don't have the therapeutic answers, but just from my experience of these cases, when I discuss patient rehabilitation with the employer, putting their recovery in terms of DASH scores and upper limb functional indices, yes, is helpful. And it's more helpful in the compensation cases and in medico-legal cases. But for instance, when the employer phones me or phones us as a team and says, well, when can Chris return to his normal duty? Because that's the only thing they really want to know. My go-to and my assessment with them is, well, at the moment, Chris is sitting at home. He is not able to, he's unlikely to be able to join his normal work. I know this just by looking at him, but I would far prefer that a therapist would go to his workplace, do a functional capacity evaluation at the workplace at various stages, and then to show someone, either the foreman or the line manager or whatever it is, and discuss with the line manager within that task ability that the patient has, what are the tasks that he can do? Because and this is again, no evidence at all, but for me, it's far more helpful for a patient to go back to his employer and discuss it as a one-on-one. Far too many times I feel there's a huge hiatus between the time that the patient gets injured and the employer first even hears about the extent of the disability. So my question to you really is, I think DASH, upper limb functional indices, are really good in terms of very intricate measures of improvement and certainly helpful. But how would you then go to the employer when I, as an employer, ask you, Robyn, listen, Chris has been away from work for 3 months. We either have two options. We need to find someone else, or we need to get Chris back into work in some form so that we can then take him forward. What would you say?
You raise such important points, and I think we need to use both scales, because you want to have a scale that's simple, grade 1, 2, 3, and 4, so that you can easily summarize where that patient's at and communicate within the team. You need to be able to do your assessments properly from the time the patient arrives through to your outcome measures, in case you need to go to court or if you need to provide a detailed report. Otherwise, you lose that opportunity because you can never go back. And I think just finding one that is very useful in terms of time, because our demands on time and with our patient is quite pressurized. So you want to have that. And then I absolutely agree with you. The third missing link is that assessment at work and what allows for it in our particular settings. And perhaps for me, my most important thing for myself and my patient is to get them back to work as soon as possible. Because if they're out for too long, it's very hard to get them back into work. And I liaise and keep communicating with the patient, the employer, all the way through. I make a call to his line manager. I have him on WhatsApp, and I send progress videos. And I just close that gap, because very often the employer might see us as the enemy, keeping the patient away from work unnecessarily. They're losing money. It's costing time. And so by just crossing that bridge and engaging with that employer, it takes away a lot of anxiety for the patient and the employer. So I take that approach. I had the luxury of doing those assessments in London. It's just not been possible for me here. And I think that it's really something that we either need to refer out to, or you can send them for a VALPA assessment where they simulate those work activities and then give an accurate response as to whether or not the patient can go back to work. Because the last thing you want is to go on gut instinct or to make an assumption and then they go back and re-injure, and then whose fault is that? And I think it's always about whether or not they're safe. So what I make sure is that they can go back as soon as possible, and they do an alternative role at work, so that if they cannot operate the panel saw, then they must do admin, and they must supervise, or they must teach. They must be back at work. They must not sit at home and get bored and get frustrated and lose motivation. And then the other thing is just sometimes those patients, especially our workmen's compensation patients, are left to fund the transport to therapy themselves. And so I often motivate to the employer to refund their transport and just help, just make it just really more useful. So yes, I think I'm guilty of not being in the position to go and do those assessments. But I think also with the subjective component of the functional capacity evaluation, where you break down their work tasks and then you look at whether or not they can do it, you then decide, can that person go back to that task, but always back to work. Does that answer your question?
Yep, I think so. No, I think it just brings home the point of how many surgeons and therapists have actually seen the places of work that our patients are injured at to get a better understanding of what it is that their demands require. And I think not many is the answer. So the other points I wanted to make, if we can move on, is I think the indications for replantation, not only for replantation, but for salvage surgery of a mutilated hand has changed markedly over the years in terms of skill level. In other words, we now know that we knew this from the very beginning, and I think it's just gotten further and further entrenched, especially with the advent of microsurgery and super microsurgery, that replantation and salvage operations are very, very doable things. And there's always been a debate as to whether amputation versus replantation, what is going to get that patient, what is better for the patient? And I think this cannot be answered simply by statistics. And this is why it's such an individual thing. Now, let's go through a couple of things. I've worked at the Ganga Hospital in India, which for me is a prime example of a setup that is geared towards treating these injuries. So they have a drainage population of 30 million to that one hospital. They have a policy that everyone in the surrounding vicinity, probably up to 200 kilometers around that hospital, knows that that hospital is the replantation center. At any one time, they have 3 plastic surgeons and 3 orthopedic surgeons on call. Their policy is that any severely injured patient does not stop in their casualty or their ER. They go straight up to a pre-theater room where the anesthetists take care of them, where they're triaged and any life-threatening injuries are dealt with at that stage. If it's only an upper limb injury, the anesthetists at that stage start to put a block in. And this could be a supraclavicular block so that the patient has complete analgesia. A discussion is then had at that stage between the family, the patient, and the surgeons as to the viability of that hand, as to what the operative procedure involves, and generally what the outcome would be. And based on those factors, a decision is made as to whether to continue with salvaging the limb or whether to provide other options, whatever they may be. And then within probably 3 to 4 hours of that patient having been injured, whether it be a car accident or a factory incident, that patient is actually being operated on. Once the operation takes place, there usually is a team of 2 or 3 surgeons that are involved, and all simultaneously working together. It's actually beautiful to see. And at the end of the day, within 4 or 5 hours of that patient being on table, they're then off table and within a care area to recover, but having done most of that work. Now that compared to where I am in George, where my case that I did 3 weeks ago was injured in Beaufort West. Beaufort West is a town that's probably 450 k's away from here. He was then flown into the George Hospital, which is a provincial hospital. And by the time he got to us, he was then now at least probably 10 hours post his accident. By the time we'd got him to theater, it had at least been 14 hours post his accident. So these are the kind of, idiosyncrasies that you work with in each environment. And I think you've got to take that into account. But the skills issue is certainly one that if you don't do these regularly, and if you don't make a point of doing them regularly, then you're going to sway yourself towards an amputation. But if you do them regularly, then all of the other things like time factors and this and that can only be improved, but can only be improved if you're actually going to provide the service to do so. You can't have all those in place without having that regular turnover of microsurgical cases and experience. And I think that's important for surgeons and for treatment groups to note. In South Africa, there's probably a handful of microsurgeons who have the time and ability to do these things, and it never happens at a convenient time. Unfortunately, there isn't one, and this is just a fact, that there isn't one set up microsurgical replantation unit in the entire country, but that's because of the resources we work within and so on. In the Far East and places like India and in the States, there are probably 6 or 7, per significant area, but that's just resource based. So I would just like to put it out there to surgeons if you're interested in microsurgery and if you're interested in any form of salvage surgery, then certainly avail yourself to it. It may not be financially rewarding to you, but it certainly is gratifying to do the cases.
How many microsurgeons are there in Johannesburg? Do you know?
I don't know offhand. I don't have an answer to that, but I would say that pretty much every single plastic surgeon who is trained in microsurgery. That doesn't mean that they probably postgraduate training do microsurgery on a regular basis. So I would say that there may be a dozen or so regular microsurgeons up in Johannesburg who on a regular basis do microsurgical cases. And even within that group, it is, when you look at a severe upper limb trauma, if it's your first case and you really have not much assistance, or if you have not been part of a team that's been doing it, it's extremely difficult to get the ideas flowing in your own head as to how to approach that case. When it comes to shortening bones, doing a one bone forearm, not being afraid to strip every dead thing out of that forearm so that it looks evacuated. And you think to yourself, how on earth am I going to get this together? But you need the principles in your head. And I think all of that only comes with experience, unfortunately.
And I think from a therapist perspective, although I haven't been in the theatre with you when you've had that patient that's come in with a traumatic amputation because it's an emergency, but I know with my planned scheduled visits to theatre, they are so invaluable. And I think you grow your relationship, a therapist-surgeon relationship, you understand each other's work. As a therapist, you can scrub up and assist. And I think every therapist should be doing that at least once a month. I mean, it's certainly helped my practice so much, and explaining to the patients.
I have no doubt that in my mind that every single therapist should, if you're working with a certain set of surgeons or a single surgeon, you should know everything that your surgeon does, and vice versa. I think it's equally important for surgeons to visit their therapists at their rooms and just see what they do. So,
sure.
Yeah, it doesn't only work one way.
Yeah, exactly.
Can I just say one thing about rehabilitation postoperatively with respect to SIMS and also with respect to pain-guided movement and with respect to relative motion, the idea of relative motion splinting. I think all three of these therapies or modes of therapy steer clear of the fact that of the principle that we should operate and we should leave things to recover for long periods of time, and then only once things are healed should we start to mobilize. So without doubt, early mobilization is key for edema control, is key for brain-hand interaction. It is key to get normal patterns of movement back rather than allowing patients to go away, develop abnormal patterns, and then try and unlearn those patterns. Once again, there's no, and this is where I think the problems come in, is that the evidence is there and it hasn't been collaborated in an effective way from a rehabilitation perspective to say that early active mobilization, and that's why the dogma of casting, or not casting people, but splinting people and splinting patients for such long periods of time has just kind of continued forever and ever. But I think, Wendell Merritt's group with relative motion, the ideas of pain-controlled motion, and your technique of SIMS certainly has brought about a thing where therapy doesn't stop when you leave the therapist's door. Therapy is every single day, every single minute, every single time. And that's what SIMS allows, that's what relative motion allows, and that's what pain-controlled motion allows. But it has to be with guidance, and it has to be with a one-on-one guidance between the therapist and the surgeon and the patient, which is why at day one, I always expose my wounds, and I always just try, whether I'm doing a zone 2 flexor repair or whether I'm doing I try as soon as possible. Well, if it's a zone 2, I may just wait 3 days, elevate the limb, and tell the patient to elevate the limb, but see me at day 3, and then in my office, tell that patient to then show them what is a third of a fist, what is a half a fist, and what's a full fist. And then let them, under my guidance, do that initial motion. Because if I'm afraid I'm going to snap the tendon at day 3, then it stands to reason that I'm going to snap that tendon anytime I move it. So if I haven't repaired it properly, it is the surgeon's fault. It is, in my mind, just about never the patient's or the therapist's fault that the tendon has snapped. Because if you've done an adequate repair, other than patients who would deliberately go and rupture your tendon by doing something silly, if you just spoke to that patient, told them what it's about, and told them how to actually protect that tendon, then guided protected motion is actually very, very good and helpful to healing. And I think your SIMS technique has, certainly in my hands, has its very good indications and is extremely good at getting brain-hand patterning back together and allowing, despite the fact that you think you're immobilizing joints that are good, it allows support to those joints so that those joints that are stiff are then isolated, and that patient can, in a supportive environment, start to move those very joints that you need moved. As opposed to this thought process of, well, you're taking a good joint and you're making a bad joint. I don't think you are. And secondly, just because you're using plaster of Paris. Plaster of Paris is breathable, it is a natural fiber, and it is, for wound healing, in my opinion, much better than any fiberglass or any plastic material that you could make a splint out of. So both from a wound healing perspective and edema control perspective and a brain-hand coordination perspective, the actual casting, and therefore it's not just a back slab, it's a full cast, gives you that intuitive feedback each time you make a maneuver. And I think that really helps.
Thank you so much, Chetan. I think absolutely it's non-removable, which means that the patient has to work with it and work within it. And we don't need to worry about the wounds, because for millennia, patients have been put into plaster of Paris with wounds. So there's no limitation with this technique, and it just highlights that the sooner we put them in that plaster of Paris cast, the better, because they may only then be in it for 2 weeks versus waiting down the line. Chronic stiffness is now present, persistent edema is there, now they need to be in a cast for a long period of time. And And I think especially when you've got changing anatomy, when you've taken a toe and you put it on a hand, you've got to get that patient to accept that that toe is now a thumb. And that is something that is happening on a cognitive level. It's not something that's going to work because you put the toe on the thumb and it's now post. It has to, the same with the tendon transfer. It's the same with the replantation and any any kind of nerve damage. You have to connect the brain, and that is the secret, and that is the key. And the secret for therapists is to educate their surgeons, being open, discussing it, and taking the ideas to their surgeons so that everybody's on board. Because if you just do it and the patient arrives in the surgeon's office with a cast and he has no idea about the technique or what you're thinking or what you're doing, they are going to be upset or not understand it. And we want the patient to feel the confidence from the surgeon. If the surgeon says to the patient, you have got to use this technique, and I'm sending you to the therapist for this technique, they arrive half the battle's won for us. So it just really highlights our teamwork. So thank you so much for reiterating that to the therapist, because you're going to give them inspiration to go and tackle the issue with their surgeons. Because although it's not a new technique, it's just not a popular technique for many reasons. And we're going to change that just through the beauty and the power of social media and through webinars like this. Thank you so much, Chetan, for supporting the technique.
Pleasure. Thank you, Robyn. Thanks a lot for the webinar.